su proposta di questo webinar che è nato su proposta di alcuni soci e soci dell'AIE. E tale invito è stato poi raccolto dal gruppo di lavoro AIE Pace e dall'Associazione Italiana di Epidemiologia e dalla rivista Epidemiologia e Prevenzione. Con diverse iniziative AIE, AIE Pace ed EP sono impegnati da tempo a riflettere sulle molte crisi umanitarie dei nostri tempi che sono legate alle guerre e ai conflitti armati. E ci tengo a richiamare la dichiarazione che abbiamo predisposto in circa un anno di lavoro e sottoscritto nel novembre 2023 con numerose altre società scientifiche e sanitarie a favore della pace e contro la guerra in tutte le aree del pianeta. E potete trovare i materiali di questa dichiarazione e altri materiali sia sui siti dell'Associazione Italiana di Epidemiologia sia sul sito di Epidemiologia e Prevenzione. Il webinar di oggi, questo webinar, vuole affrontare da un punto di vista epidemiologico, come è scritto nel titolo, e da un punto di vista della salute, l'attuale terribile crisi di Gaza e quindi le sofferenze e distruzioni che dal 7 ottobre 2023 subiscono le popolazioni coinvolte. Io ringrazio fin da subito il gruppo di lavoro AIE Pace per il lavoro organizzativo svolto e tutte le persone che prenderanno oggi la parola e contribuiranno al webinar. Scrive bene Epidemiologia e Prevenzione che noi come epidemiologi abbiamo più che mai il compito di dare voce ai dati. Quindi la prima parte del webinar sarà dedicata alla loro analisi, alla comprensione e discussione dei dati. Nella seconda parte rifletteremo invece su azioni in ambito sanitario e scientifico, sia a livello nazionale che a livello internazionale. Stiamo affrontando un tema vasto che scuote le coscienze, quindi vale la pena di ricordare che il webinar ha un focus sanitario ed epidemiologico anche nella sessione di discussione, che è parte integrante del webinar. E aggiungo che in ultima analisi possiamo dire che questo webinar vuole dare conto della follia della guerra come massima minaccia per la salute della popolazione. Questo webinar sarà registrato, quindi sarà possibile poi rivederlo in seguito. Alcune informazioni di servizio, le domande e commenti andranno scritti utilizzando la funzione question and answer oppure domande e risposte su Zoom. Potrete scrivere in italiano oppure in inglese anche durante le presentazioni degli oratori e la discussione sarà poi gestita negli appositi spazi da Pirus Fatemogadam, che è anche l'anima organizzatrice del webinar ed è co-coordinatore del gruppo di lavoro AIE Pace. La moderazione della seconda parte sarà invece gestita da Francesco Baranadesi, che è co-direttore scientifico di Epidemiologia e Prevenzione. I will now switch to English for the first part of the webinar, which will be in English. So for our English-speaking colleagues, I reiterate that I have just introduced the webinar, emphasized its epidemiological perspective, and thanked the speakers. I recommend to all the speakers to stick to their allocated time to allow enough time for the discussion. And I will, to help you, I will notify when your presentation time is coming to an end. So the first speaker today is Sandro Colombo, who is a former WHO officer and is a well-known expert in field epidemiology and humanitarian crises. I thank all the participants to this webinar. And now I hand over to Sandro. So Sandro, the floor is yours.
Thank you, Lorenzo, and thank you, Pirus, for putting this webinar together and for inviting me. And good afternoon, everyone, and greetings from El Escorial. Let me share my screen. Can you see it?
Yes.
Yeah.
But you should put it on full screen.
This is what I'm trying to do, but I cannot find a way.
There is a slideshow, maybe, in the middle of the upper part of the screen. Yeah.
No.
It's down the down. Bottom, left, right, close to the slide, that Zoom slide, down, at the bottom, at the real bottom.
No, I cannot find,
Yeah,
sorry.
that one, Sandro, that one is the one. That is the one.
Okay, sorry. Okay, so this is the outline. I will speak on mortality estimates and update on mortality estimate in Gaza, and then on the recently declared famine in Gaza. These are two topics which are complex and have, on the technical point of view, and have significant humanitarian and political implication. Given the limited time, I will give only a snapshot of the topics, trying to limit the technical details to a minimum. But I have added a few slides to the end for those who are not very familiar, mainly with malnutrition in emergency. So, starting with mortality, a quick introduction on what is the impact of armed conflict on health. Armed conflict results in injuries, traumas and injuries, disabilities, and mental health problems, and both have require long-term health care and sometimes specialized care, and excess morbidity and mortality, which are morbidity and mortality above the pre-crisis baseline. And I will get back to this point, which is important. Mortality and in particularly excess mortality is a key metric in humanitarian response. It serves different purposes to gauge the severity of the crisis and humanitarian need, to guide the humanitarian response in terms of which intervention should be implemented, which strategy should be applied. It can contribute to the evaluation of the effectiveness of the humanitarian response. It documents human rights abuses to hold people responsible for human rights abuses accountable, and for advocacy for the protection of civilians. It has been used in Gaza. The first study by the London School, and Zeina was one of the authors, was used by South Africa in the case against Israel. It has been used in the document in the International Association of Genocide Scholars and the recent UN independent inquiry. And also to raise the visibility of humanitarian crisis. And this is just an example. In early 2000, the International Rescue Committee did a repeated surveys of mortality showing that more than 3 million people had died because of the conflict in the eastern part of Congo. And this raised the attention of politicians and government, and almost overnight the humanitarian funding doubled. Conflict-related deaths create a lot of controversies for two reasons. One, the limitation of studies in conflict in humanitarian crisis context. All studies, surveys, or estimates have limitation and are prone to biases. And then the political nature of mortality data. And the government who are involved and responsible for human rights abuses tend to deny or minimize estimates, like Israeli government dismiss the estimate that were produced. Going now to Gaza, I will not discuss this complex table, it's just a reference, and I described the studies in editorial for Epidemiologia and Prevenzione a few months ago, so you can find the details and the references in this article. But I will try to highlight some of the data of more recent study that came out after the editorial. The first one, I don't know if you can see the laser, but can you see the laser point?
No, we can't actually.
No. Okay, so I will do it with the pointer.
Now we can see it.
Yeah, the first independent mortality survey, which was carried out according to the standard household surveys done in emergencies by Spagat and other, use the typical cluster sampling, 2,000 households and around 10,000 people interviewed, and led to an estimate with interpolation from the sample to the overpopulation of Gaza, of a total of 70,000 direct deaths. Direct means caused by violence, directly by the conflict. This is important to see that the period cover stops at the January 2005, so it's not updated to now. It also showed that 56% were women, child and elderly, so the least likely to be fighters, combatants. And also for the first time, it assessed the indirect deaths that were not caused by violence, but by the collapse of health systems and other systems. Then MSF did a survey. There are no details on methods. I couldn't find a full report. And they looked at mortality in their staff, in the staff of MSF and their family. So it is not a representative sample. Probably MSF staff are better off than the average people in Gaza because they receive a regular income and they have an easier access to healthcare. And they found, again, a very high crude death rate, 5 times more than the baseline, but they didn't mention which was the baseline they used. And for under 5, the death rate 10 times the baseline, with a very good matching with the of their data with the Gaza Ministry of Health. Then there was a demographic study carried out by another group, and Zeina was one of the authors, so maybe she can expand in the presentation. They look at the loss of life expectancy, which was again incredibly high, more than 20 years of loss of life expectancy. Then going back, there was another study looking at the, well, I have no time to discuss the survivor bias, but it's a bias which is quite common in surveys in humanitarian context, and applying different levels of adjustment to the survivor bias and to the cohabitation, multifamily cohabitation level. They expanded the estimate of the Gaza mortality survey, the study number 8, to have a higher number of deaths. The most recent Gaza Ministry of Health data reported by the UN 1 week ago give a total of 65,000 people dead. And these are almost exclusively direct traumatic deaths, even if the Ministry of Health started in July also to collect data on malnutrition. But I will go back to this point later on. Finally, this is not a study, just a statement from ex-IDF, Israeli Defense Force Chief of Staff, who stated and was reported by the newspaper The Guardian that more than 200,000 Palestinians have been killed or injured during the war. And this stated, and I will not comment, this isn't a gentle war. We took the gloves off from the first minute, sadly, not earlier. The ratio civilians and fighters. So according to the Zeina and Spagat studies, 55–60% of casualty involve minors than 18 years, women and elderly. As I said before, the least likely fighters. There was an IDF database, classified database, which was leaked and showed that 83% of the killed were civilians, again reported by The Guardian. And these are very high ratio, and only a few other contests have shown a greater proportion of dead among civilians. In Srebrenica during the Balkan Wars, in Mariupol in Ukraine, and during the Rwanda genocide of Tutsi, which was the totality were civilian. In the interest of time, I will not discuss the data on the people killed seeking aid, food aid and other aid. In the Gaza Humanitarian Foundation, you know, this new system of delivering aid by Israeli and with the American backup. And there are data from the Ministry of Health and also from MSF. So a few thousand people killed were waiting to receive aid. Quickly, some preliminary conclusion that I could draw from the survey. I think that the number of studies is quite high, considering the indirect access to Gaza and all the difficulties, and also the ethical issues concerning collecting primary data in a context like Gaza. And much higher than, for example, in Sudan, which probably is the worst humanitarian crisis now, where a few studies have been carried out and few estimates are available. Different methods and different periods, which make it difficult, impossible to have a consolidated number or to validate, because they refer to different periods with different intensity of the violence of the conflict. Most studies, with the exception of the one that I mentioned before, Spagat, look only at direct deaths, so traumatic deaths, and not the indirect deaths. There is some consensus on the fact that the Ministry of Health data are an undercount, they're underestimated, also because with the passing of time, there is always a degradation of the routine information system, which, by the way, my experience when I worked in Gaza before the conflict was quite good, was quite robust. So around 40% from Zeina studies, Pagas study, there is an alignment of an agreement of about 40% of underestimation. A very high proportion of civilian among the deaths, between 55 and 80%. This is the range. The human cost is dreadful. We can assume that probably about 10% of Gaza population may have been killed or injured, severely injured, and the majority being women, children, and elderly. And then, last but not least, even if the ceasefire were signed tomorrow, the burden of diseases and the mortality will continue and will accumulate over time, because of until there will be a restoration of some normal life, and there will be a restoration of health system and the other systems that are key to maintain people alive. So the crisis will not stop with the ceasefire. I'm going very quickly because the time is limited. I will move to famine in Gaza. Famines have marked the history of humanity, and famine has a very strong, how can I say, emotive power because of the extreme loss of life. Well, this is the picture of the 4 horsemen of the apocalypse, and the third one on the black horse is famine. And famine, well, I start with the good news. It seems that there is a trend of decreasing number of famines, declared famines, and also a diminishing number of people who died because of the famine, as compared to the previous century, where what Alex de Waal called calamitous famine, famine with more than 1 million people died, were quite common, mainly in Asia. Just to give some example, the Holodomor famine in Ukraine in 1933-34, or the Nazi hunger plan, or the worst, probably the worst recorded famine, the Great Leap Forward of Mao Zedong, with more than 30 million people died because of the policy of collectivization. In this century, in this quarter of century until now, 4 famines have been declared. Somalia, South Sudan, only some countries, some IDPs, internally displaced people, camps in North Darfur, and in Gaza Governorate just a few weeks ago. And we don't have an estimate of excess death, is too early. And they have all in common war as a key driver of famine. And in Somalia, there was a combination of drought and war. But war is a common factor which led to a famine. Famine are easy to recognize because of they are not only extreme hunger crisis, the outcome of a cumulative process of food insecurity, not only hunger crisis, but a collapse of the society, a breakdown of the society, erosion of cohesion of community bonds, and very extreme behaviors of desperate communities. So until 20 years ago, the famine were defined as using metaphors, like is like water freezing to ice, is like falling from a hill. Alex de Waal, who is probably the best or one of the best scholars of famine, define famine as putting together food insecurity, malnutrition, and mortality. And we'll try to expand a bit on these three key aspects leading to famine. As I said before, in recent famine, hunger has been used as a weapon of war, but also in the past, and had been used as a way to destroy the enemies. A few weeks ago, the Famine Review Committee, which is a group of independent experts in food security, nutrition, epidemiology, and Zeina was a member of this Famine Review Committee, which looked at the data from Gaza and came out with a declaration of famine using the IPC, which is the Integrated Food Security Phase Classification. I will explain what it is. And they reached the conclusion that famine is occurring in Gaza Governorate, and emergency is occurring in the other 2 governorates in Deir al-Balah and Khan Yunis. No data on the north of Gaza, which was inaccessible, or it was impossible to obtain the data. What is the IPC? IPC was developed in early 2000 by a group of people working in the Horn of Africa in Nairobi, and is a scale of intensity of food insecurity. In 5 color-coded different phases, going from minimal to famine. It's a composite of 3 kinds of data with the indicators and benchmark for each phase. The prevalence of food insecurity, and just to define, food insecurity involves availability of food, access to food, physical but also economic affordability of buying food, is use of food for a healthy diet and stability, lack of shocks, economic shocks in the price of food. The prevalence of malnutrition, for those who are not familiar, in emergency, our concern is global acute malnutrition or wasting. Children mainly who are thin, while chronic malnutrition, children who are short, stunting. So I go back also to this point of malnutrition and mortality. These are the three areas for which data are collected and are used for the IPC classification. As I said, it is an intensity scale, looking at the severity of food insecurity, but it's important also to look at the magnitude of the number of people who are affected by food insecurity and also to the duration of the crisis. So as of now, probably Gaza is the most intense food insecurity, but also Al-Fasher in Darfur at the same level of intensity. The magnitude is probably represented by Sudan now, the number of people affected by food insecurity and by hunger, and the duration, probably the example are Democratic Republic of Congo or Yemen. This is a summary of the IPC, which has been used. It goes from the minimal food insecurity to stress, crisis, emergency, and catastrophic or famine. For each phase, there are key indicators with benchmarks and also implication for action, what should be done. This is a tool to guide decision makers for the intervention to be applied when we move from a crisis to an emergency and to famine. And for famine, the three indicators are 20% of food insecurity, households facing an extreme lack of food, 30% of children suffering from acute malnutrition, or 15% using another indicator that I will show, and 2 deaths per 10,000 per day as mortality, which is a very high level and was not used for Gaza because the baseline mortality for Gaza is much lower. This is mainly used, was mainly defined for Sub-Saharan or Horn of Africa countries, which have a baseline mortality much higher than in Gaza. So how do we measure nutrition in emergency? We have 2 indicators. The first one is comparing the weight and height of the children between 6 to 59 months to a reference population of children, and based on the deviation for the median of the reference population, less than 2 standard deviation or less than 3 standard deviation, we define moderate or severe acute malnutrition. It's important to note that for acute malnutrition can be reversed, while chronic malnutrition, stunting, cannot be reversed. Sometimes there is no possibility to carry out a survey, and we use the SMART methodology, SMART is standard monitoring of assessment and relief and transition. So we use a tape, a color tape, and we measure the mid-upper circumference of children, again, between 6 and 59 months. And less than 12.5 centimeters, the child is defined as malnourished. So looking at the food insecurity, this comes from the report of the committee, the Famine Review Committee. You can see that the darker, for the north of Gaza, we have no data, but the darker is the color and the more severe the situation of the red. The dark red is famine, and the light red is emergency or stress. The same for nutrition. So in the governorate of Gaza, the situation was defined as famine. And this is the trend of GAM, is global acute malnutrition, measured by MUAC, the middle upper circumference, which saw an exponential growth, increase of malnutrition in just 3 months, going above the threshold of 15% prevalence of global acute malnutrition. Just a quick mention of the relationship between malnutrition and mortality. The acute malnutrition is associated with an exponential rise in mortality, and malnourished children are more susceptible to infectious diseases. So dying by starvation is very rare. Children and also adults die because become susceptible to common infectious disease, common diarrhea, or respiratory diseases. Common diseases that normal children in a normal situation could cope and could survive, but because of the impaired immune system, because of malnutrition, they died if they are not treated with specialized care, with therapeutic feeding. And by the way, the decrease in the lethality that I showed at the beginning is partly due to the big advances in public health, and mainly in nutrition in recent years. What has been observed that in Gaza, diarrheal disease is rising and the vaccine coverage is decreasing. So the mortality by malnutrition is likely to increase over time unless there is a ceasefire, there is an inflow of aid. Malnutrition can be also a contributing factor to mortality not only for communicable diseases, but also for non-communicable diseases. And another problem is that many children die at home, and non-traumatic deaths are not easily reported. They are contributing factors, but are not the immediate cause of death. So it's difficult to have reliable data on mortality due to malnutrition. Gaza is a special case of famine under siege, and this because the coping mechanism, the mechanism that the community is affected by famine use when there is a situation of severe food insecurity are not possible in Gaza. And what people do, normally they start selling their assets, what they have, furniture, a bicycle, whatever they have. They ask for loans by if there are people who can lend money, or remittances from overseas, from relatives overseas. They start reducing the consumption of food, or they start eating wild fruits, berries, and so on. They move to places, to towns where there are opportunities of income. All this is impossible in Gaza because all the agricultural sector has been destroyed, and the fishing sector, because the displacement is a forced displacement, and because there are no more job opportunities. Already before the war, the unemployment rate was extremely high in Gaza. There is a systematic attack on the workers' infrastructure, so all the treatment of malnutrition is extremely difficult. As I say, destruction of agricultural and fishery sector. There is a humanitarian blockade, so no, apart from the ceasefire in January, February, aid, and not only food, but also medication and all the therapeutic feeding products, which are vital for treating malnutrition, do not enter Gaza or enter in a very short supply. And Israel control every drug, every sack of flour, every shekel. Shekel is the currency that is used in Gaza and in Israel. Forced displacement, so people are moved from one side to the other, and what I mentioned before, the system of aid distribution was in place before by UNRWA and by other organizations with more than 400 distribution points has been replaced by this Gaza Humanitarian Fund, only 4 hubs where people have to move quite a lot to wait and to be victim often of violence. And this just to show.
Sorry,
this,
Sandro, but I have a task.
I have only
Yeah.
I have only 2 slides, so I'm finishing. This is just to the food by entry point, land route, and these are Israeli, the source Israeli government. You can see that after the ceasefire, there was a fall of a dramatic decrease of food by in metric tons after the ceasefire. And this is the last slide. The title is behind the statistics. There are individual tragedies. There are 3 quotes. The first one is by the top UN humanitarian official, Tom Fletcher, the emergency relief coordinator, who says food stacks up at border because of systematic obstruction by Israel. It is a famine within a few hundred meters of food in a fertile land. So there are hundreds of trucks outside the border of Gaza, ready to enter, but they are blocked. There is an optimistic, I cannot read because, let me, yeah, now I can, sorry. Alex Wall gives an optimistic view. Mass starvation could be ended for good if we decide that it is to be so. As humanitarian and public health expert, we have a role to play to provide data to try to influence decision, but in the end, it is the politician who have the possibility to change the situation. And Ogata, the former UN High Commissioner for Refugees, said there are no pure humanitarian solutions to humanitarian problems. I stop here. Thank you for your attention. And as I said before, there are extra slides not to be present, of course, because of lack of time, for people who want to know more about the benchmarks or how nutrition is assessed. And I stop here. Over to you, Lorenzo, and thank you for your attention.
Thank you, Sandro. Thank you for this overview, and there will be time to discuss in the question and answer session. I see that there are questions, so please remain, of course, in the webinar, and you will get some questions.
You better, sorry, Lorenzo, you better ask Zeina, who knows much better
now I'm going to introduce.
Than I do. No, any question should be
addressed. It will be after Zeina. Now I'm going to introduce Zeina Jamaluddine, who is here with us, and from the London School of Hygiene and Tropical Medicine, and she will speak about this capture-recapture as a method for mortality estimate in Gaza. So, Zeina, the floor is yours. We can see the slide, so you can start whenever you want. Thanks.
Perfect. So thank you, everyone, and thank you for inviting me to discuss. So I'll be also talking actually about two big topics, the mortality and the food insecurity and the famine. And so it follows really nicely after Lorenzo. So thank you, Lorenzo. I want to talk about 2 years ago and as our role as epidemiologist and as a nutritionist. So I have both trainings and I have worked in the region, and I was working on creating a cohort of Palestinian refugees using the UN data. And then the war started. And so just to go back 2 years ago and to talk about mortality estimation, and I don't know if any of you remember, but on the 26th of October, the president of the US said that he has no confidence in the number that the Ministry of Health is putting out. And like any war, there are a lot of the fog of war and numbers become contested. And so the Ministry of Health in Gaza has released a listing of the names of every single person that was killed from the 7th of October till the 26th of October, with ID, with sex, with the age, and the location of where they were killed. And there are many people who took this data to validate it, to look at it, to question it. And we have done some of the work to try to understand, as epidemiologists, what is the mortality pattern and what is happening in Gaza. So if you look at the simple age in the x-axis and the y-axis is a rate. And if you look at mortality of males and females, which is in dark blue, males in dark blue, females in dark red. And then we looked at mortality from other sources. So the UN employees and the data of healthcare workers. And so we could clearly see that there was overlap. But then we also looked at the ideas, and we and others have examined these data sets. And as Lorenzo mentioned, Gaza had excellent health information system before the war. Now, of course, other people come and say, but there is no correlation between women and daily women killed and daily children killed. And actually, we know that data doesn't happen in a second. We know that if it reported mortality of a woman and the next day there is the reported mortality of children, actually, this is not a linear association. And there has been a lot of that questioning of this type of use of statistics to actually show that there's no correlation. But what really made the whole question again is when the Ministry of Health released that in June, that was in 2024, is that 36,000 people were killed. But then what we see is that 24,000 are actually identified. So we only have the names of 24,000, and there are 10,000 under the rubble. And so this made people question again the numbers of mortality in Gaza. And so what really happened? So what happened is that, like any war, health information systems get degraded. But what even became worse is the attacks on the hospital that Israel conducted. And so at the beginning in blue is the number, dark blue, is the number that came from all the hospital morgues of people killed from the health information system. And then they took the unidentified from media and put them in. And every time the reporting of the hospital decreased over time. So at the beginning, we had 9 out of 9 hospital reporting, then 6 out of 9, then 5 out of 9, then 3 out of 9, then 2, then 3. So some of them opened back again, then 5. So we could clearly see over time the reporting from hospitals changed. So the ministry decided to also do a survey where they asked people to fill in information of those that were killed. So they asked them to put in information of the relatives, how they're related to them, their ID, the gender, where they were killed. And so when the whole fog of the war happened about what is this unidentified or this gray, we came together and we thought there has been methods used before by different colleagues and to estimate mortality, but also estimate numbers historically. And there has been work that was done in Sudan, in Colombia, in Yugoslavia to try to estimate using this capture-recapture method. And I'm just going to be very, very simple in explaining it. But what is this method? This method relies on listings, using a listing of mortality from one list, then looking at the overlap with a listing of mortality from a second list, and then a listing of mortality from a third list in order to really understand the mortality not captured by any of these lists. So this mortality that's on the side. And the idea behind it, and this is not just a graphical representation of it, is that if we have more overlaps, so there is more names in multiple lists, the people unidentified would be less. And so, of course, you build models. So you put a model with different models, with different intercepts and parameters. You could adjust, and you run these analysis to come up with with those that are not captured by any of these lists. You could use a Poisson regression, you could use Bayesian models, and so on. And we've run all of them, many of them, and they're all available in the appendix. So what we need is actually listings. So we have the listings of people that were killed by the hospital. We have a survey that people have filled in, and there has been overlaps between those two because people don't go and look at the hospital list, and people were reporting their family members that were killed. And then we had to use a third list. And so we went in social media because in Gaza, there was a lot of reporting in social media about the names of those that were killed. And we scraped the internet for the name, the location, the age, the gender of the person that was killed. And we did a whole listing from social media of those that were killed in Gaza. We used all of this information to do the capture-recapture analysis. Now, we first do a bit of descriptives to see that the majority were reported in October, and then there was a decrease. And actually then after June, which doesn't exist in this figure, it went up again. So there has been different points of proportions of those that were killed. We also then looked at the age distribution from the different models and the gender distribution. So female, males, and we adjust the models for them. So we do include these in the model, the age and the sex of the person. And so we do this overlap, as I mentioned, and based on that, we generate this data set that has if your person A is killed and reported in the hospital list, if they're recorded in the hospital and the survey list, if they're reported in all three of them, in order to estimate what is outside any of these. And we've used an Italian statistician, who actually Rossi, to actually come up with the models of using Poisson regressions mainly to look at how many were outside of any of these lists. Now, instead of using one model only, we use the posterior probability and the AIC to weight the models. Now, this is just based on the Rossi-Poisson regressions, but it's possible to also look at the Bayesian models and the other ones that are available in the appendix. But sort of, if you look at all of them and all the different models, we come up with the fact that the Ministry of Health is reporting 34,000 deaths. The actual estimate from this modeling is around 64,000 deaths. And that is actually where the idea of the 40% underreporting comes from. That also later on, Spaggett, with his household surveys, they actually show similar numbers. And I think this is important because it's showing with two different methods that we are coming up with similar estimates of what's happening. And so with household surveys have their own limitation, capture-recaptures have its own limitation. So coming together different methods, we have confidence intervals, and the confidence interval also overlap between the household survey and the capture-recapture. And so there is that more evidence into what is the true estimates of mortality, and that's till June 2024. Now, I want to talk a bit about the age and sex distribution of the death, because I think this is very important. I think it's the fact that when we look at the age, which is the x-axis, so 0 to 14 and 60 plus and so on, and the annualized mortality rate, and the males and females, we actually see that overall we have a rate ratio of 14 times. We're 14 times more likely to die in Gaza. And it is possible that the Ministry of Health data does include non-traumatic death. It is possible that the non-traumatic deaths that are not in the reported by the survey or not reported as non-traumatic, we are under capturing them, but it's not always how to say clear cut, and this becomes also an issue with conflict, and how do we report traumatic versus non-traumatic death. The annual mortality rate is around 39 per 100,000 per thousand. And children under the age of 14 were 24 times more likely to die in Gaza. Now, why am I talking about the pattern of mortality? It's because if we look at UN-IGMI data for other conflicts, so this is the age distribution, and again, the mortality, and this is the demographic assessment. If you look at other conflicts and the estimation of mortality, the estimation is not the dotted line. The estimation is the dark line. The dotted line is the conflict. If you look at earthquakes and how people are dying in earthquakes, so the majority are children and then like more 60 plus. But if we look at data from other genocides and we look at what's happening in Gaza, we can clearly see the overlap between them. And so this is all information into the fog of war happens, but also how can data be used to showcase what's happening and as evidence and accountability of what's happening. I will not discuss this in details. I will just talk quickly about the excess mortality. As Lorenzo mentioned, in wars you die from aerial ground war invasion, and there is also other excess mortality coming from insufficient food, infectious diseases, and the big one is actually an epidemic happening, and so a cholera outbreak or a polio outbreak. Back in November, as a team, we tried to look at how much the excess mortality is going to be under different scenarios. And that was November 2023, but the projections were released in 2024 in February. So this is all now history. But just to say that we looked at what would happen if we got a ceasefire in February 2024. And we know that mortality will still be in excess because hospitals are not working. What would happen if an escalation happens? So which was actually the Rafah incursion. And we tried to model, based on different diseases, what's going to happen. So the idea is that you have infectious diseases, you have COVID-19, you have different pneumonia, and you're not getting treatment for them. Then we looked at whether a cholera outbreak, a polio outbreak, what would happen in terms of mortality. Then we looked at maternal and neonatal. So there is no access to NICUs, no access to blood transfusion for pregnant women who actually need and have a hemorrhage. And what would be the excess mortality because you cannot go to hospitals? And the big one for Gaza that people do not talk about is actually NCDs. Gaza, before the war, had very high prevalences of non-communicable diseases. I will tell you, the model of NCD that we did is actually very limiting because it's actually very complex. And we were doing it under a time crunch. And if anyone wants to further model these, I think would be, sadly, we're seeing more and more wars in the middle of not only infectious diseases, but NCDs being very dominant and people not having access to life-saving interventions. You have a heart attack, you don't go to the hospital. You're having more chronic diseases, more hypertension, diabetes, and so on. And so just as an outline, we saw that one of the big causes of mortality is going to be a cholera outbreak or a polio outbreak. And actually, in light green is the ceasefire, in purple is the escalation. And these are going to be the biggest threats in Gaza. And the other one was measles and meningitis. We then also look at maternal and newborn. The number is going to be small. So in gray is actually what would have happened before the war. We know neonatal death happens, but it's just how much excess is going to happen from neonatal death because of no access to premature NICUs and so on. And so the number is small, but the reality is that if you look at maternal mortality rates or neonatal mortality rates and these numbers, we saw actually in Gaza 20 years ago. And so even with a ceasefire, this is still going to be a huge excess mortality and a reversal of all the mortality numbers that are in Gaza. finally, the whole NCDs, and the biggest one, we're looking at survival analysis. So you do not have access to insulin. How much are you going to survive? And using these to come up with diabetics, so mainly diabetes type 1. How long are they going to survive without insulin? How long are they going to survive without strokes? Now, all models, all models do not have limitations, and we know that. And happy to discuss further. But just to say that these have been used by different people and activists to say that if we have a ceasefire in February, 74,000 lives could have been saved. And this was released back in April, and now we are a year later, if not more. And sadly, the reality on the ground is still ongoing. And just to say that this is, if you look at the two branches, the one with the leaves actually shows a ceasefire where we would still have excess mortality. But then the one that is still going up is the one where an escalation is still happening in Gaza. Now, I'm going to be the most brief about food insecurity because I'm a nutritionist. And one of the big things is that before the war, I was looking at overweight and obesity in Gaza. I was looking at mainly weight for height measurement and wasting. So what Lorenzo was mentioning, the thin kids was actually 1%. And the focus was mainly that how much we are witnessing in this region, overweight and obesity and what's happening and so on. And I worked a lot on food insecurity. And so we start this war and different narratives happen on food. And I want to say that there has been people saying, like the mortality, that there is only 240 calories per capita per day in Gaza. Others actually saying there's enough food in Gaza, not a problem, there's 3,000 calories. And all of those are studies and that are available. But as Lorenzo mentioned, there are 3 ways and 3 criteria to classify famine. And so one of them relies on food availability. So calories is one of them, but also food insecurity reported by people. The acute malnutrition, so the thinness of the children, and mortality. And as researchers, we try in conflict to actually collate and triangulate data. And the same way we did with Capture-recapture, sort of, is to look at data from different sources. We wanted to understand how much kilocalorie is really available in Gaza. And so at the beginning of the war, around 50% of households were food insecure, but the majority of households, around 70%, were relying on food assistance. And so this is some of the work we've done before, but to say that there are food in warehouses, there were food in stocks, and there were food in personal people's stocks. And we used this data from different places to come up with how much kilocalorie was available before, but then to see as the war moved on, how much kilocalories was available from agricultural land. So FAO did a lot of satellite images to show how much the agricultural land is decreasing. There has been very good reporting by all governments to show how much airdrops was happening, which basically was barely 2% of calories in the north, which is like a lot of amount of money being thrown for propaganda, basically, and you could really track it very well in all the governments who did that on their websites. And then finally, there is the trucks that came in, not only the UNRWA ones, but also the private sector and all of that were tracked as kilocalories coming into Gaza. And just to say, this is at the beginning, this is not now, and we've done that now also, is at the beginning, we had around 2,800 kilocalorie per capita. And what FAO and you could also calculate it as a population, we usually need around 2,100, which is the dotted yellow line. And at a certain point of the war, in the beginning, in the north, this line dropped to 1,000 kilocalorie per capita. After the killing of the World Central Kitchen, there was an opening of the borders, and then the calories went back up. And then they went back down, and after the ceasefire went even more down. And just to say, why is this important? Because this is the first component of the famine classification. Sorry, I live now in Lebanon, and electricity cuts is normal. And the second thing is that we look at the not only kilocalories, so availability of calories, but also to try to understand acute malnutrition.
I'm sorry,
And this-
Zeina, but I'm just doing my task of telling you to remind about the time, please.
Okay, so I'm almost done. Just to say that basically we try to project how much acute malnutrition would be in Gaza, and actually, like Lorenzo mentioned, it's funny because I use the same slide as him, is to show that basically they decrease in both. That we see an exponential increase in acute malnutrition in the same way as the projections, and also we use all of that for famine classification. Finally, I want to say that we talked about data, and we talk about numbers and the reality on the ground and how all of these data could be fed. I want to end with just the idea that we use all of that for accountability for what's happening currently in Gaza, of the people that were killed, doctors, university professors, journalists, students, and children. And so I just want to finish on that note, and thank you so much.
Thank you, Zeina, and sorry for reminding about the time. Thank you for your presentation, Sandro's presentation. I will now hand over to Pirus Fatemogadama, who will handle the question and answer. So Pirus, I can see you.
Yeah. Yeah, thank you so much for your very, very interesting presentations. We have a couple of questions. The first, they were in Italian. I translate in English. The first one is from Luca Vignatelli, and he wanted to know: is there any information available on how the Gaza Ministry of Health operates in terms of the personnel involved, data collection methods, territorial coverage, and analysis capabilities? Thank you. So I think part of the question, he put in this question during the talk of Sandro. I think Zeina already answered quite a bit of this question, but I leave it to you both to further answer. And then we have two considerations by Emmanuel Segre Amar. And the first is, he did not mention, he is Sandro, they came in the, during the presentation of Sandro. He did not mention that for us, children under the age of 18 are combatants in Gaza, and that leading British and American military experts have stated that in no other conflict have there been so few civilian casualties in relation to combatant casualties. Since Emmanuel Segre Amar wrote for us, I should mention us, I think, is because he's the president of the Zionist Association of Piemonte. So the us refers, I guess, to his associates. And so for them, children are not combatants, and I think this is related to the second part of the statement as well, because of course if you declare the civilian population as combatants, then the rate is, but that's just my interpretation. I leave it to you. And furthermore, the casualty figures are those provided by a terrorist group and do not take into account the casualties caused by Hamas, which Israel makes public on a daily basis. And the latest consideration is 80% of food entering in the strip was taken by Hamas for its own men and to resell at high prices, as the population is crying out to the world. So I leave it to you to comment and to answer these questions and comments.
Yeah. Sandro, do you want?
Zeina, maybe you want to answer the question on how the data are collected. I mentioned before that, and it was also my experience in Gaza, when I work in Gaza, that the electronic information system was quite robust, and I was working for WHO at the time, and So I worked with the data, and they were quite consistent. And as I said, and Zeina stressed with passing of time because of other priorities and because of destruction of hospitals, which were the center of the information system, the quality of the data degrade. And this happened in all the world. What he says about Hamas stealing the food, I don't know what is the evidence, but I am familiar with how the food was distributed before the war, and there was absolutely no stealing of food. I was very close to WHO and UNRWA were working together. I was present in the distribution of food. There was absolutely no stealing of food, and in relation to the quality of the data of the Gaza Ministry of Health, Zeina already explained that the data were compared with other data, independent data, and they showed that the quality at the beginning was quite good, and with time there was an undercount, an underestimation because of the number of deaths and because of other priorities, because of destruction of infrastructure for a health information system. So I would like, and I asked him what is the evidence also of the young people combatant. Of course, among minor of 18, there could be fighters, but I say the least likely to be combatants. And I would recommend the person who is asking the question to go back, and I could provide him with the distribution by age. And if he says that children of 8, 9 years or 5 years are combatants, I challenge him to discuss. So please look at the distribution by age, and of course this does not rule out that some of them could have been among the fighters. And I leave to Zeina maybe the part on the data collection and of the Ministry of Health, because she worked on the validation of the data, and not only she and the London School of Hygiene and Tropical Medicine, but also Paul Spiegel and others look at the data, and they confirm that the data were valid with some limitation, of course, not precise to the last figure, but quite valid. So there have been several attempts to look at the data, to compare with independent data, for example, the distribution of deaths among UNRWA staff and so on. So Zeina, over to you.
So I think Sandro, sorry, I called you Lorenzo. I'm very sorry, Sandro, in the presentation. I'm very sorry. So Sandro basically really depicted them really well. In terms of the sources of the data before the war, the Ministry of Health was actually relying on this health information system for COVID-19 reporting. So you'd find some of the COVID-19 stuff that were reported in Gaza was using the same system. And so there is actually a study that looked at the quality of the health information system and how much they were not capturing. And so they were trying to do some sort of a quality check with ICD-10 codes and to try to really look at if the system was working well. As the war progressed, the system degraded, and some of the hospitals stopped reporting them. And so yes, it happened more and more actually with the war. Sandro mentioned also, there is some group that works on wars called Air Wars, that looks at every single person killed and looks at the social media and the different reporting to look at civilians, to really collate a huge data set with geospecific location of those people killed. And they also find that some of the people that they found on social media are not available on these lists, and vice versa. So it's like they were trying to look for names, and I think they were able to find most of the names. And they have this huge exercise that they're still doing now, and they do some in other conflicts. There's a bit of a debate about 18 or 16 or all of that. The data in the Ministry of Health is reported by the age, so the date of birth, and you could basically regroup it and classify it as you want. In the analysis we've done, we looked at 0 to 14, and we find 24 times more likely to be killed than before the war, and these are 0 to 14-year-old. When we talk about this 18-year-old and the 16 to 18-year-old, some of them might be combatants, but also some of them might be people who are going to get the food, because they are men who are more agile and more able to go to these centers to get the food. And so a lot of the time when the airdrops, you actually see young men going to get this. And just to say that they're more exposed and they're more likely to be killed, but also they're more likely also some depending on that. But actually this whole argument of does a 17-year-old is a child or not, I don't want to go into that debate, but what I want to say is that just look at the mortality distribution and the distribution of mortality of the population pyramid in Gaza, and what's the population pyramid, what's the mortality distribution, what's the mortality rate by age, and you could come up with your own conclusions about what's happening, and that how much these mortalities are overlapping, whether the age distribution and the population pyramid. Finally, I also want to say there was a question about the assistance. Like any war's assistance is different systems. The problem is the current system that's being put in Gaza. There has been documentation by forensic architecture showing how much it actually disables people from getting these assistance. People are being shot, and this is something new that we're talking about in terms of people being shot while they go get assistance. There's around 2,000 that were killed. Those are not classified as mortality as for famine, but actually they're directly linked to food insecurity. People who are risking their lives to go get food. And this is not documented by the Ministry of Health. This is documented by FAO, by WFP, by WHO, and so on. So just want to say that today in Gaza, people are risking their lives to go get food. And so if you are food insecure enough to risk your life to go get that, and knowing that these are very high likelihood of dying. Actually, if you look at 2000, after the ceasefire, we've calculated that. I don't have the number on top of my head, but I think 1 out of 3 killed after the ceasefire was because they were getting food. I would double check that, but it's in the famine review committee. It's in different reporting. But if you look at the total people reported killed after the ceasefire, like the most recent ceasefire, and the people killed getting food as a cause of death, they were actually like one of the leading causes, actually. So I will leave that up to you.
Thank you very much for this answers and comments, and I hand over back to Lorenzo so we go on with our program.
Okay, thank you, Pius. Thank you all. My task is just to hand over to Angelo Stefanini and to say that now we will switch again to Italian. Angelo Stefanini, former WHO health officer, occupied Palestine, and volunteer for Palestinian Children's Relief Fund. Ti lascio la parola, Angelo.
Ok, grazie. Bene, si vede tutto bene?
Sì, si vede, grazie.
Ecco, allora già il titolo della mia presentazione dà l'idea del contenuto. È un tentativo di mostrare come la distruzione sistematica del sistema sanitario a Gaza può essere visto come uno strumento per compiere genocidio. L'organizzazione Safeguarding Health in Conflict nel 2024 documentava attacchi all'assistenza sanitaria nei conflitti in tutto il mondo nella misura di 3.600 incidenti, il 15% in più rispetto al 2023 e il 62% in più rispetto al 2022. Il maggior numero di attacchi, più di 1300, hanno avuto luogo a Gaza in Cisgiordania, molto più di quanto sia mai stato riportato in un conflitto in un anno. Accidenti. Ecco. Qui un aggiornamento purtroppo soltanto al 24 settembre e quindi non tiene conto degli ultimi eventi tragici e soprattutto a Gaza City, ma riporta l'OCHA 14 su 36 ospedali parzialmente funzionanti, 9 ospedali da campo su 18 parzialmente funzionanti, il 36%, 65 su 181 di centri sanitari periferici funzionanti e in termini di vittime 1722 operatori sanitari uccisi dal 7 ottobre 2023. Naturalmente gli ospedali e le strutture sanitarie sono protette dal diritto umanitario, dalla Quarta Convenzione di Ginevra, dalla risoluzione 2286 del Consiglio di sicurezza del 2016, dallo Statuto di Roma, che è quello che ha creato la Corte Penale Internazionale. Ma questa protezione viene a cadere se le strutture sanitarie vengono utilizzate, al di là dei loro obblighi umanitari, per recare danno al nemico. Questo è quanto dice la Quarta Convenzione di Ginevra. In caso di dubbio si deve ritenere che non sono usati a questo scopo. Comunque vada, i 3 principi fondamentali della condotta in ostilità devono essere rispettati, che sono il principio di distinzione tra civili e combattenti, il principio di proporzionalità che sostiene che il danno arrecato deve essere proporzionato al guadagno, diciamo così, al beneficio militare ottenuto, e il principio di precauzione che intende minimizzare il danno ai civili. Perché vengono attaccati gli ospedali? Il Comitato Internazionale della Croce Rossa ha riassunto in 4 motivi, diciamo così, ragioni, il fatto che vengono attaccati gli ospedali. Il primo caso sono attacchi deliberati per ottenere un vantaggio militare, oppure attacchi per motivi politici, religiosi o etnici. Altra ragione sono i danni collaterali, cioè non intenzionali, e infine il saccheggio di medicinali e attrezzature mediche, come è accaduto nel 2003 a Baghdad con il collasso virtuale dell'intero sistema sanitario. Nel caso di Israele, perché attaccare gli ospedali di Gaza? Ci sono delle motivazioni ulteriori. Beh, il primo, vediamo, è la convinzione di Israele che gli ospedali siano usati da Hamas per nascondere armi e centri di comando. Le prove non sono ancora state portate in modo indisputabile, ma comunque questa è la motivazione principale apportata. Secondo è la convinzione, e questo è molto diffuso nella popolazione, che la vittoria finale giustifichi una violenza letale su Gaza. È un po' quello che dice la dottrina Dahia, che sostiene, che approva l'uso di una forza sproporzionata volta a cancellare le infrastrutture civili, compreso il sistema sanitario. Altro motivo è per rendere ovviamente i palestinesi, farli sentire insicuri, farli sentire che nessun posto è sicuro e quindi minare la volontà di resistere, la loro volontà di resistere, una specie di guerra psicologica. Infine, motivo centrale è quello di rendere Gaza inabitabile, in pratica per impadronirsi della terra senza la popolazione indigena, che è un po' la logica di eliminazione che fa parte del progetto coloniale di insediamento del sionismo, un po' una nuova Nakba, una pulizia etnica, un genocidio. Vediamo un po' di ricordare cosa dice la Convenzione del genocidio, come definisce il genocidio. Il genocidio è definito come uno qualsiasi dei seguenti atti che vengono commessi con l'intenzione, con l'intento, questo è centrale, con l'intenzione di distruggere in tutto o parte un gruppo religioso, razziale, etnico o nazionale. Questi atti sono uccidere membri del gruppo, causare gravi danni fisici o mentali ai membri del gruppo, infliggere deliberatamente al gruppo condizioni di vita intese a realizzare la sua distruzione fisica in tutto o in parte, imporre misure volte a prevenire le nascite all'interno del gruppo e trasferire forzatamente bambini del gruppo in un altro gruppo ancora. Questa immagine, prodotta dal sito Visualizing Palestine, intende cogliere la distruttività onnicomprensiva del genocidio a Gaza, cioè la distruzione di massa delle case, il domicidio, distruzione intera delle città, l'urbicidio, l'ecocidio, distruzione dell'ambientale, culturicidio, scolasticidio, la distruzione del sistema educativo. Quello che manca qui, come potete notare, è la componente medico-sanitaria, che però, faccio vedere, gli studiosi, gli esperti si sono sbizzarriti a trovare un nome da dare a questo componente come medicidio o medelacidio, da medela, che in latino vorrebbe dire cura, medicina, iatrocidio, iatros dal greco medico, e healthocide, cioè chiamiamolo salutocidio. Il gruppo di ricerca multidisciplinare che si chiama Forensic Architecture, che risiede al Goldsmith College University of London, e il cui leader è Eyal Weizman, un israeliano, in un rapporto di oltre 800 pagine analizza la condotta dell'esercito israeliano nel primo anno di guerra, mostrando la distruzione quasi totale della vita civile a Gaza. Particolarità di questo rapporto è che cerca di identificare modelli all'interno della violenza compiuta, cioè la ripetizione di atti uguali, simili o correlati in tempi e luoghi diversi. Tali modelli indicherebbero che questi attacchi sono organizzati e progettati piuttosto che verificarsi in modo casuale o fortuito. Vediamo il caso del prendere di mira sistematico, dell'attaccare sistematicamente gli ospedali. Questo gruppo ha evidenziato che l'esercito israeliano ha ripetutamente preso di mira le infrastrutture mediche a Gaza, e la loro analisi indica che il prendere di mira gli ospedali da parte dell'esercito segue uno schema, un modello coerente e distinguibile di 5 fasi consecutive che alla fine portano alla cessazione della funzione di quell'ospedale. Queste 5 fasi sono: primo, l'evacuazione, gli ordini e gli avvertimenti di evacuazione dell'ospedale, poi attacchi nei dintorni dell'ospedale, attacchi diretti all'ospedale, assedio dell'ospedale e invasione dell'ospedale. Questo rapporto, questo gruppo ha evidenziato come praticamente tutti gli attacchi e gli ospedali distrutti o danneggiati hanno subito questa sorte. In particolare, il gruppo, Forensic Architecture, ha tracciato, verificato, mappato e correlato tra loro quasi 2000 eventi individuali al fine di far emergere modelli comuni, appunto. Tali modelli hanno indicato che questi attacchi sono organizzati e progettati piuttosto che verificarsi in modo casuale. E cosa dicono letteralmente? Che la condotta dell'esercito israeliano a Gaza indica una campagna, l'esistenza di una campagna organizzata e sistematica per distruggere la vita, le condizioni necessarie per la vita e le infrastrutture che sostiene la vita. Esempi di questo comportamento sono la tempistica degli attacchi agli ospedali, che è legata alla presenza di civili sfollati. Tutti gli attacchi erano sempre pieni di civili che si erano rifugiati dentro gli ospedali. Gli operatori sanitari sono target diretti, sono bersagli diretti e non vittime indirette. L'esercito israeliano distrugge e occupa ospedali anche dopo che sono stati evacuati, cioè gli ospedali sono andati vuoti, sono andati distrutti quando erano già stati svuotati, e un danno particolarmente serio è stato inflitto ai servizi di maternità, quindi servizi riproduttivi. Lo stesso, in pratica, è quello che, la stessa conclusione è quella a cui arriva la Commissione internazionale indipendente d'inchiesta, che ha pubblicato il 16 settembre scorso il suo rapporto, in cui documenta la presenza di genocidio a Gaza, e ho estratto due paragrafi. Il paragrafo 208, che dice: la Commissione constata che le autorità israeliane erano consapevoli del fatto che, distruggendo il sistema sanitario in tutta Gaza, le loro azioni avrebbero portato alla distruzione dei palestinesi come gruppo. E il paragrafo 243, la Commissione conclude che le azioni di Israele costituiscono violazioni degli obblighi derivanti dalla Convenzione sul genocidio, quindi che sta commettendo genocidio. Infine, credo che l'immagine più iconica, simbolica della distruzione del sistema sanitario di Gaza sia quella del dottor Hussam Abu Safia, arrestato il 27 dicembre 2024, che è il direttore dell'ospedale di Kamal Adwan, che è tuttora detenuto nelle carceri israeliane. È stato da poco, senza accusa, è stato da poco incontrato da Physicians for Human Rights Israel, che l'ha trovato in condizioni serie e allarmanti. La sua liberazione, credo, dovrebbe essere uno degli obiettivi primari di chi lavora e lotta per il diritto alla salute e alla vita della Palestina occupata. Grazie.
Bene. Virus a te. Penso che sia importante aprire un question and answer.
Sì, per adesso non sono arrivate domande quindi se volete rivolgere qualche domanda a Angelo Stefanini, questo è il momento.
Ora mai più.
Se non ci sono domande, potrebbe essere utile
Guadagnare tempo, no?
elaborare su due concetti. Il primo è la questione citata all'inizio del fatto che non ci sono evidenze dell'uso militare degli ospedali. Su questo sarebbe utile approfondire. Ovviamente approfondire sulla mancanza di evidenze non è facile, ma capire come si è arrivato a questa conclusione. E l'altra cosa che io non ho capito dalla presentazione, ma forse in realtà sono comparsi dei dati su quanto siano gli ospedali funzionanti al momento rispetto a quelli che erano inizialmente funzionanti. Forse è passata una slide, ma rapidamente. E ovviamente queste domande in attesa di vedere se ce ne siano delle altre. Vedo che ce n'è una Pirus, quindi forse si possono raccogliere anche altri input.
Sì, e Sabrina chiede, può ripetere la lettura della prima slide sulla quantità di attacchi in Palestina maggiore ad altri conflitti? Sulla questione, se mi è permesso, sulla questione dell'uso militare degli ospedali, forse anche un'altra considerazione è importante, vale a dire che il diritto internazionale è molto chiaro su questo. Le strutture sanitarie godono di una protezione speciale. Questa protezione può essere persa qualora il nemico utilizza gli ospedali per azioni militari. Questo vuol dire proprio azioni militari, semplicemente la cura di anche combattenti feriti non è considerato un uso militare di un ospedale. E rispetto alle prove mancanti, anche qui il diritto internazionale è chiaro, in caso di dubbio deve rimanere lo stato di protezione speciale. E qualora anche fosse provata la violazione del diritto internazionale, quindi si usa l'ospedale come una posizione da cui fare combattimenti, non viene a cadere il principio della proporzionalità. E quindi,
No,
soprattutto
no.
considerando come dire, l'accusa anche della presa di ostaggi, no? Di human shields, e se questo è il caso, va ulteriormente con ulteriore cautela e dovuta a un'eventuale azione militare, proprio perché ostaggi o scudi umani non possono per loro definizione scappare e quindi bisogna mantenere un elevatissimo cautela negli attacchi. Questo credo è evidente che non è in nessuna maniera stato una considerazione o rispettato. Io mi fermo
Sì,
qua.
se posso aggiungere, non solo il principio di proporzionalità, ma i tre principi fondamentali, distinzione, proporzionalità e precauzione, valgono sempre, anche quando
Esatto,
viene violato, anche quando perde
la
la
protezione
protezione.
speciale.
Sì.
Esatto.
Per quanto riguarda i numeri, riguardo al numero dei casi, degli incidenti di violenza contro o ostruzione all'accesso ai servizi, 1361 sia Gaza più Cisgiordania nel 2024. Questi sono dati che sono pubblicati, questa è una pagina di questo rapporto Safeguarding Health in Conflict, che è accessibile e in fondo alle referenze trovate anche il link. Non ricordo cos'altro.
Grazie. Non, non vedo altre domande, quindi Lorenzo, visto anche
Va
il
bene.
tempo,
Grazie, grazie ancora e anche dell'aver dato l'opportunità di approfondire ulteriormente. Forse c'è una domanda sul numero di ospedali
Ah,
riuniti.
sono,
Questo,
come ho detto, purtroppo non abbiamo i dati dal 24 di settembre, perché in questi ultimi giorni sono successe cose molto gravi le associazioni umanitarie, a cominciare da Medici Senza Frontiere, se ne sono andati per questioni di sicurezza. Quindi l'accesso ai servizi sanitari è estremamente ridotto, se non assente. Però i dati che avevo dato erano di, mi pare, 14 o 16, 14 ospedali su 36 in totale che erano parzialmente funzionanti come ospedali. Poi un terzo invece dei centri sanitari periferici che sono strutture, e io ve lo dico per esperienza perché andavo laggiù a lavorare con loro, estremamente, estremamente efficienti ed efficaci e con una distribuzione sul territorio molto, molto intensa. Quindi sì, i dati ovviamente sono ancora da aggiornare a queste ultime settimane. Il rapporto dell'OCHA prossimo uscirà domani, quindi l'ultimo è quello di martedì, cioè di venerdì.
Ok. Pio, scusa se ho fatto questa
No, ho
precisazione.
visto, sì, benissimo, perché ho visto adesso Francesco Zambon, non avevo visto la sua domanda sulla questione che gli attacchi su civili sono giustificati dal fatto che i bersagli erano militari o che quel sito c'erano esponenti di Hamas, e poiché appare evidente che non è così, perché Israele non è accountable per questo e rispetto a chi. Però penso che ne abbiamo già risposto un po' a questa questione, no? Dell'uso militare, eccetera, eccetera. Quindi